Jacques Devie. I work in Brussels. I'm there the chairman of a medical surgical department, and I've been asked by the foundation to coordinate the activity of gastroenterology. So gastroenterology means the management of patients with GI, liver and pancreatic disease, but also all the aspect of endoscopy, therapeutic and diagnostic endoscopy, which is an integrated part of the specialty. So in the last 2 years, we have built up a unit with physicians who have been recruited for their expertise here in Lisbon. And we are now able to offer almost all the type of management for those patients who have GI disease, and especially GI disease which are related with any kind of malignancy and premalignancy. So Champalimaud Foundation is based on the multidisciplinarity of management of patients. They have been able to create very quickly a very experienced group. For an example, the guy who convinced me to come here is Celso Matos, with whom I have worked for more than 35 years. And we have built up a center where we can take in charge patients with pancreatic disease very quickly, managing them by doing imaging and diagnostic endoscopy and general GI management, and offer very quickly a solution or a proposal for treatment. So of course, here in the foundation, you have this beautiful place, the atmosphere, which is very quiet, but also besides this quiet atmosphere, you have an efficacy which is really at the top level. And one patient, and this is an example with the fast track program that we are creating, what we offer is that a patient who has a problem with the pancreas, not necessarily a pancreatic cancer, it can be a cyst or anything else, but you know, when you have a problem with your pancreas, you are always worrying, whatever you come from. And there are many places, not only in countries of the Middle East, of Asia, or United States, or Europe, where it's difficult to find a center which is specialized in this type of problem. So we have tried to offer a service which gives the patient an answer and a proposal for treatment within a maximum of 4 days. This is something which is extremely difficult to obtain in many places of the world. And it's not necessarily more easy to obtain when you live in Europe or when you live in the United States. And you know that more and more medicine is becoming specialized. And if you are becoming specialized, you need to put the people with the maximal expertise together. And I think that in some areas for management of premalignant disease or suspected malignant disease or proposal for treatment, the foundation has been able to gather these people who have unique expertise in a dedicated area. So the gastroenterology is by definition a group of disease, the digestive disease, which require the participation of multiple doctors with different specialties working together. Can be radiologists for imaging, can be gastroenterologists for medical management and endoscopic therapy, and surgeon. And I've been raised in a medical surgical environment. You know, in my unit in Brussels, I'm in charge both of surgery and gastroenterology. But my specialty, my own specialty as a gastroenterologist, is not surgery. But what we do is replacing surgery in many instances. So the therapeutic endoscopy is everything you can do as an intervention going through the natural orifice. So it can be through the mouth, through the anus, but from there you can do many things because the material we use has been dramatically developed. This kind of flexible endoscopy has developed since the year 70s. But just to give you an example, there are some kind of disease like the severe cholangitis, for which the mortality in the 60s was more than 30%. which has been reduced to less than 2% now, and this is mainly due to the fact that we are able to do this management with a less invasive therapy, because as soon as you do not open the abdomen, the therapy is much less invasive. But what is really the future in my discipline? The future is currently already available, and this is what we want to offer here in the foundation. The therapeutic endoscopy can afford treatment now for any kind of superficial tumor of the GI tract. I treat more esophageal cancer by endoscopy without opening the thorax and the abdomen that the surgeons who are working with me are treating, because we are diagnosing this disease earlier and earlier, and therefore the entity of gastroenterology, and this is the future, has to combine an early diagnosis. This is the screening, this is also part of the treatment. This is the screening of high-risk population. Then you have an early diagnosis, then you can offer an early treatment, and this early treatment will be less invasive with less complication. In the other area, the future is also the access through the natural orifice to any structure. You know that we use also echoendoscopy, EUS guided therapy, that means a flexible scope, and at the tip of this scope you have an ultrasound probe, and then you can get access to all the cavities or all the organs which are around the GI tract, which is very important for staging of malignancy, but which is also very important for treatment. And these developments are now going to non-cancer related disease. As an example, over the last year with my colleague Ricardo Rio Tinto, who is gastroenterologist here, we have acquired probably one of the largest experience in Portugal in management of achalasia by doing peroral endoscopic myotomy, which are all therapy which were only possible by open surgery or laparoscopic surgery, and which have completely moved now to flexible endoscopy. And I can cite many other diseases, but the future of this specialty is to combine the best medical management. The best medical management means that you don't treat a picture, you treat a patient, and you treat a patient if there is a real indication, and you think in a multidisciplinary environment about this indication, and you discuss this indication with your colleague. You don't treat the patient in your corner without an open discussion with the other. But also you are able to offer the most outstanding technical management to this patient, looking for the less invasive procedure which is able to cure the patient. And this is where the place of flexible endoscopy, which again is not surgery. It's another discipline, but is doing a kind of surgical procedure without opening the abdomen. And this place is growing and growing, and I'm convinced that it will continue to grow in a multidisciplinary environment in the future. So less invasive is better for the patient because the recovery and the risk of complication in surgery is not only related to the treatment you do on the organ that you have to modify, but also on the access you need to go to this organ. So the typical example is the management of morbid obesity. Morbid obesity is a disease, as you know. A patient who has a morbid obesity has a life expectancy which is 20 years less than a normal person. But just to go to the stomach, you have to go through an amount of fat and the abdominal wall, which is quite difficult, and it makes the surgery more difficult. And this is why those patients who have a Roux-en-Y gastric bypass, they need to have very experienced surgeons to do that. If you can do that through the mouth, then you come to the organ without the need of any dissection before, and therefore the recovery time is much shorter. Another example that we have developed here, and we have done now many cases in the foundation, is the management of Zenker diverticulum. The Zenker diverticulum is a disease which very often occurs in older patients, above 60 years old, but up to 100 years old. And the Zenker diverticulum is a diverticle which is at the posterior wall of the esophagus. If you want to treat it by surgery, you have to open the neck of this patient and go very deeply to cut the diverticulum. I have developed this kind of treatment that we have done now in more than 300 patients, where you go through the mouth with a flexible, simple device. You cut the septum. It's a 15 minutes procedure. You just target the organ you want to treat, and the patient can go back home the same day or the night of the treatment. So that's really what changed, is the access we change, and all the morbidity which is related to the access to the structure you have to treat. So I think, and this is something that I already discussed before, the design of this institution is very in line in what we want to do in the future organization of medical care. I'm not telling that all the hospitals in the future will have the same design as this outstanding place, but the design of this place is made to offer the most difficult and treatment at the technical edge, at the clinical edge of medicine, within a short period of time, to those patients who need it, and who can later on get another care in a more standard hospital, because we have no emergencies here up to now. We have an intensive care unit, we have an outstanding recovery room for surgical or therapeutic endoscopy case. But this is really what would be the future, is you have a referral place. You need to have a disease, and a disease which is not so frequent. So you have to look for the best group to treat this disease. And this best group can be in another country than the country where you live. But once you have identified this best group, or the group which is amongst the best in the world to treat this particular disease, you can come there, they offer you the treatment in the best condition, and then you continue your general care within your own hospital or with your own doctor. So this is really a referral place. And I think this is what we need in the future. We will not be able to offer the most difficult treatment in any place, because all the material, all the infrastructure that we need to be at the top level in this development cannot be afforded by many places. So this is in this line. I think this place where you have also research, and research is important because once you want to develop new treatment, you may have new ideas. So working with the engineers who are not far from it, or working with the scientists, is also something important. This is more at the long term, but I also think that at the long term, these outstanding referral centers like the Champalimaud Foundation will have to be close to research center, because this exchange, this translational research, will have to take place for the future development of medicine.